My name is Matthew Koff. I'm an assistant professor of anesthesiology and critical care medicine at Dartmouth-Hitchcock Medical Center. This is an educational video about the esophageal Doppler monitor. Here are some clinically relevant examples that you may see in patients. This is the display you would see on the cardio-cue with a hypovolemic patient. The waveform bases are very narrow, indicating a short ejection time. The corrected flow time is only 220 milliseconds, far below the norm of 330 to 360. The stroke volume is 45 cc's, and the heart rate is 94 beats per minute. The cardiac output is low for this age and size of patient. You may expect a cardiac output in the range of 5.5 to 7.5 liters per minute. The effect of the fluid infusion, as shown here, gives you real-time monitoring, and the result of your fluid challenge is shown. The stroke volume has increased by 31% to around 59 cc's, and the corrected flow time by 34%. Both of these measurements indicate that a further bolus should be given. After a second fluid challenge, the stroke volume is now 72 cc's, an increase of 22%. The corrected flow time has increased 13% and is now at the low end of the normal range. More fluid is still needed to optimize this patient. Even though the cardiac output appears to be normal, this is due to tachycardia following the fluid challenges. The heart rate will shortly return to normal. A third aliquot of 200 cc fluid bolus is required. The patient is now optimized after 600 cc's of fluid. The stroke volume has increased by only 8%, and the corrected flow time by less than 6%. You have achieved the top of the Starling curve. Fluid administration should stop, and the patient should be monitored for any ongoing changes. This is an example of a patient with complete and massive hypovolemia. Notice the short waveform base, the fast heart rate, the low cardiac output, and low stroke volume, and low flow time corrected. This is an example of a patient with cardiogenic shock, low flow time corrected, and peak velocity showing a high afterload state. You can try a fluid bolus first. However, if that does not work, you can reduce the afterload with a vasodilating drug. Then you can try a fluid bolus again, remembering that a patient with cardiogenic shock has a very flat slope on the Starling curve. This is an example on induction of a patient with known aortic stenosis and left ventricular failure. The flow time corrected may well be prolonged due to compensation of slow emptying time. After an hour and gentle filling, cardiac output went up, stroke volume went up to about 60, peak velocity went up to about 50, both of which were low. Flow time corrected went up to around 400 milliseconds. The shape of the wave also shows left ventricular failure. It has a flattened wave indicating less contractility. This is the same type of picture you may get with left ventricular dysfunction, a reduced height due to reduction of the contractility of the heart muscle. This is a very septic patient. A very high flow time corrected and peak velocity indicates low resistance and a very hyperdynamic patient. The patient is very vasodilated and also filled. If the flow time corrected was normal or looking low, it could mean that there is vasodilation, but circulating volume has not caught up, so a relative hypovolemia. This is an example of aortic regurgitation. Normal forward flow above the line with flow under the diastolic area due to backflow occurring during diastole. This is an example of valvular noise, low-frequency sounds caused by valve noises. They cut through the waveform and distorts the green line. A filter here should be on, but care with the filter as it reduces cardiac output and may make the waveform narrower. This is an example of a venous waveform. It has a low-frequency sound, and there's no characteristic descending aortic blood flow signal as noted at the positive spectrum of the Doppler waveform. This is an example of an intracardiac waveform. This is an example of the esophageal probe being placed too far down distally. and you're picking up the celiac artery. Notice the large waveform, often with white training through the tail area. Parameters are often too high or too big to believe. Withdraw the probe and listen for the loudest, sharpest sound accompanied by the tallest and brightest waveform. In conclusion, I'd refer you to the Deltex Medical website, where they have links to individualized goal-directed fluid management strategies, clinical evidence with randomized controlled trials, clinical education, and National Technology Adoption Center how-to and why guides from the United Kingdom.